Hi everyone, welcome to the part 2 of the vestibular myogenic potential meeting. Some of you have attended our first and some of you are attending part 2 as a first attempt to listen to our webinar. Welcome. We have two of us here today. Trina's here and I'm Jill Craig, the product manager. If you have any questions, please direct them to the question section on the side bar there. You can type in your questions as we go along. We have a couple tips and tricks and rules to try and follow as we go. All of you are muted just to reduce the background noise here. And as I mentioned, there's the question box on the side. You can type your questions in. We'll try to get through the webinar and then answer all the questions just so we can get all of the information out to you and then reply at the end. If you experience any technical problems or need support, please direct your message to that question box and Trina will get to them as we get as soon as possible so we can relieve you of any issues that you're having. So we appreciate you following those tips and tricks. Some of you, as the last time you know, my name is Jill Craig. I'm one of the product managers at Odometrics. Specifically, I follow the otoacoustic emissions and evoked potential product lines, so that's why I have the great opportunity to present to you the VEMP information today. And pretty exciting. We have over 180 people that signed up for the VEMP information and more than 35 countries. I think it's really exciting to see how many people across the world are investing their time to learn more about VEMP. And 60 people didn't let us know where they're from, which is okay, but I just think it's so exciting to know that everybody's trying to learn more about this technology and how they can implement it into their practice and how they can help patients and get to that diagnosis faster by using this test to try and figure out what's wrong with these patients. Dizzy patients are so hard to figure out and dig deeper into figuring out what's wrong with them, and VEMP is such a great new test to put into our test battery. So I think that it's so exciting that everybody is trying to learn more about this test. So part 1 last week we did a general overview of VEMP and a review of anatomy and physiology and a general review about results, just simply so everybody's on the same page of terminology and know the very basic part about VEMP so we can move into patient preparation and talk about collecting data properly and the tips and tricks and pitfalls of testing these patients. Because if we don't know the basics, we can't just jump right in to test patients. If we don't know the basics, we can't know what good data and bad data is. If we don't know the basics, we can't all talk the same language about these tests. And if we don't know the basics, we can't share information on the same level. So last week was that basic information guide, and this week we can actually look at test protocols and test parameters and how we collect data, and we can look at the same information and all be on the same page. So that's what we're going to do today, and hopefully pass some really good information on to you so that you'll be able to test your patients and get good information out of your equipment and get good information from the patients that you're testing. So let's start off with a poll this morning, or this morning for me, sorry, some of you are at the end of your day or even in the middle of the night. So let's do the first one about the current use in your clinic today. In your clinic, do you currently perform CVEMP, OVEMP, both, or neither? Let's get a check here of what everybody is using in their clinic, so if you can just let us know. I think it's always kind of interesting because we're going to learn about both today, because I want everybody to kind of know that each are really easy to perform, as much as some of them, one may seem more difficult than the other. Let me see, give it just a few minutes for everybody to click their answer. Got about 70% of the people voted so far. All right, so let's go with what we've got. We've got almost 45% perform just CVEMP, 0% perform just OVEMP, 35% both, and 18% neither. So we've got some new people learning about how to perform these tests, so that's great. All right, everybody can get a good view there. So we had about 74% vote. Super. So then let's keep going. Patient setup. Let's talk about how do we prepare these patients for the test. Patient preparation, as you know, is really important. It's the only way that we're going to get good data out of the machine. So when we set up for CVEMP, we want to locate that SCM, or the sternocleidomastoid muscle, and then we want to locate the middle third of that muscle. So take that muscle from beginning to end and divide it into 3 parts. The middle third is where we want to put that electrode. And the symmetry is really important. If we put it too high or too low, we're going to get a bad effect on the results. And if we don't have them symmetrical on the left and right, we're going to get bad results. It's that simple. So we really want to take the time to line them up. Stand in front of the patient, find the middle, make sure that they're even on left and right. Make sure that they're not too high or too low. It's going to have an impact on those results. The next question is, how do we get that muscle to pop out? And by pop out, what do I mean? We want it to obviously get a nice look at where and how do we get it to pop out. So some people will turn the head and point the chin down to the shoulder. Some people actually will turn the head and point or lean the head back and up a little bit. I know that you're all sitting there doing that, aren't you? Sitting and turning and moving, and how do you get it grabbing onto it? It's different for everybody. So some people have the patient lie down, and so they're supine, and lift the head off the table, point the chin towards the ceiling. Other people who have them sitting in a chair, have them clasp their fingers together and rest their elbows on a table, put their chin in those clasped fingers, and leave all the weight of the chin, push on the hands, and that pops those neck muscles out a little bit. So some of you might have some other ideas of how to force that muscle to push out a little bit. If you want to put them in the question section under it and just put idea for SCM, put that information in, and we're happy to share that information at the end. It is a challenge. So any information you have, we're happy to share with everyone. But some that seem to work the best is to turn that chin and point the chin down towards that shoulder. That usually is pretty helpful. We always wish that everybody had a beautiful SCM like Angelina Jolie here, right? That they all would just show up like that. It would make our lives really easy, huh? But we know everybody has this guy or woman and said, oh, how am I going to find the SCM? Those large necks make it really difficult to find where to place the electrodes. They're difficult to find. You start to feel around to find the sternocleidomastoid. I think the easiest thing to do here is to remember where the origin and insertion is. So if you remember back from our anatomy classes, that you've got the insertion is the mastoid process, and that the origin is the sternal head and the clavicular head. So if you can just kind of feel around and start there, instead of feeling around in the middle of the neck trying to find it, trace it back from one of these spots. Go way down into the neck and into the sternum of the clavicle, and go back the other way and follow it that way. Or start up at the mastoid and find it there, and then move down to find that third. If you can find those 2 spots, then you're going to be able to kind of locate that third a little bit easier, at least have a starting and stopping point of the muscle to kind of guide you where those spots are. It'll be a little bit more helpful, I think, instead of just fishing around kind of blindly of where that muscle is. It's a little easier, perhaps, for you to locate that spot. Using the differential electrodes could be useful to help with the monitoring electrodes. Instead of using 2 separates, they line you up more even so that you can keep with the symmetry. of lining the electrodes up on the neck. So let's go to poll number 2 then for this. And how many of you are using monitoring now? Do you monitor the SCM contraction? You can go there and let's see how many people. So we've got 43% voted there, and we're at about a 60-40. Okay, we'll stick with that. Looks like all that have voted, or who want to vote have voted, so we'll close it up at that and leave it at a 60-40, so that's not too shabby. We'll see if we can't persuade you later to use your monitoring capabilities. We'll close that one. So yeah, these setting up your electrode montage we've got 2 here. We'll talk about running a 2-channel here so you can see where you're going to put your active and your reference electrodes here. So you've got your active at the top. Where it says VEMP left and right, for those of you that aren't monitoring, you'll exclude those, of course, because that is for the monitoring electrode there. And if you see in the center, you'll see that you've got a jumpered electrode there. You would share that lead at the sternum. That one was a shared electrode in the reference. Or you can use 2 electrodes at the sternoclavicular junction as your references. But then right on the muscle, on the SCM, is your active electrodes there. And there you can see where they're going to plug in to kind of match you up, so your actives and your references. And then here on the Charter EP200, you see VEMP, and that's where your monitoring electrodes go there. And then on the forehead, of course, your ground. I'll give you just a second to take a look at that. All right. Some patient tips. I see more and more people forget to do this. Remember to put the electrodes on the lead before you place the electrodes. When you do ABR, it's not a problem. We just stick those electrodes on the patient and then we can snap on the lead. But with VEMP, it's a little more difficult. When you start to stick an electrode on that muscle and then you try to snap the lead on, it's really, really difficult because that muscle isn't like sticking it on the mastoid bone or on the forehead. It moves around. It's not as hard as that bone. So it's much easier to stick the lead on the electrode and then stick it on the patient, as opposed to sticking the electrode on the patient and then trying to stick the lead on. So do yourself a favor, and the patient, quite honestly. And remember to instruct the patient on how to use the EMG monitor before you stick those insert phones in their ear. It's much easier then. And we'll get into how to use that EMG monitor just a little bit later. And then setting up for OVEMP, you'll notice that when we talk about OVEMP versus CVEMP, the OVEMP instructions are much simpler. Seems like it's just a much easier test to do, or requires less instruction than the CVEMP. So here you'll see that the electrodes are just below the eyelid. Active is the upper electrode, reference being the lower. And then you've got your ground electrode on the forehead. The chin could also be used as the reference with a jumper there, just as we did with the CVEMP on the earlier on the sternum. So the chin can be referenced with a jumper. And then here you could use the differential electrodes here. Makes it a little easier instead of using 2. But there again, you can see here your actives and your references, channel 1, channel 2, ground on the forehead. And then of course we don't need the monitoring electrodes there. We'll talk a little bit more about that later. And so we're going to go into test parameters and the recording now. It's hard to get through all of this in a half an hour, so I apologize. We're not going into a lot of detail. And if at some point in the future you'd like another webinar with more detail, but we have a lot to go through in 30 minutes. So we're going to move into the test parameters and the recording, and more of the nitty-gritty of VEMP testing. So The parameters for CVEMP. You read a variety of things, so you may see some things here that don't make sense to you, but there's, similar to ABR, there's lots of different ways to run these tests. So we'll talk about a couple things. So here you'll see that I've got a stimulus set for 97 dB NHL. You'll see the amplifier gains there and the high pass and low pass filters. Here you'll see the tone I have set for a 500 hertz linear envelope with a ramp of 0 and a plateau of 2. Some people will run a 500 hertz Blackman with a 2 and a 0. It really depends on the research that you read. One of the things we know is that we want a really fast onset. So some of the preferences is for a ramp of 0 to make sure that we are encouraged that we have that quick onset. But it really depends on the papers and the research that you read with regard to the preferences that you have. You'll notice that in the acquisition on the right-hand side over here, that the sweep time, we use a 50 millisecond window. I have set 150 sweeps. Really all you're going to need is probably 50 or 60, maybe 75 sweeps. You can always stop a recording. Makes it just, you don't need 150 sweeps. That's a lot of sweeps. This is a fast test, but it is done at a slow rate. So remember, we're just running at a 5.1 tones per second. So while it's a slow rate, we don't require a lot of sweeps. And then I use a -10 delay so I can see the stimulus or have that little pre-stimulus time window. So those are just a couple of suggestions. So keep in mind, you'll see a few varying test parameters based on the different facilities or different researchers that people read. So a few things will change. And then if we look at the OVEMP test settings, and these are air conduction, there again we've got a 97. In this case I put in alternating, you could do rare. I left it as a Blackman 2 and 0, again depending on the reading. You'll see here the amplifier gain is set to 1,000, different filter settings of course. Again, a sweep of 50, sweep time of 50. This I set to 200. Again, it's a really fast test, so you're only going to need 50 or 60, maybe 75 at the most for the number of sweeps. Again, it'll pop out pretty quickly. One thing I want to note, and just have it make some sense to you, think back to those amplifier gains that we had set. We have CVEMP set to 5,000 and the OVEMP set to 100,000. I think people get confused about what amplifier gain is. So why do we set the amplifier gain as we set it? If you think about this SCM muscle, and why does it only require 5,000 for gain? It's a huge muscle, right? We've just been sitting there holding onto this muscle and trying to contract it, and we can see how large it is. We're measuring that muscle, that response, how big it is. It's easy to get a response. When you think about the muscle on the eye, that tiny muscle, when you look up, we're measuring that muscle. It's a lot smaller. So it needs more amplification to be recorded. So that's why we do 100,000 for the eye, 5,000 for the CVEMP. Think of it like ABR is 100,000. It's a teeny little response. Think about ASSR. It's an even smaller response. We amplify that 200,000. So it has to do with the size of the response with regard to how much amplification it receives. So that's why we use more amplification. So when we're recording the CVEMP, here's a picture of one of our colleagues, Amy, from the UK. She's testing herself here. So let's take a quick look at the screen here. Amy is got her head to the left. She is recording her EMG here. And you can see she's got about 45 accepted sweeps here, and she has a nice CVEMP coming out. That's just a general view, so we're going to give you some more details as we go. Amy's actually just running herself at 90 dB, the 500 hertz tone at 5.1. So if we go on to the next screen, what she's done is she finished, she ran 50 sweeps. And what I want you to notice is while she collected her EMG, she collected with the EMG monitor open, wide open. So she didn't set any parameters. She left it open, and she had an average of 98 microvolts. So when we run with this open at 98 microvolts, she gets her average was 98 throughout. When she's finished, she's now going to change these min and max, we call them, and she's going to set it to 20 below. The min will be set to 20 below, and the max will be set to 20 above. That's going to be her window for her EMG monitor at this point, for the rest of her recordings. So we know where the patient is able to comfortably turn their neck and have that muscle contraction. So that's her min and her max. The first one is run wide open like that, and that's what gave her the green. So now she's going to run it again. Obviously these are a different setting, but so what in this case, if it's red, she's above the max. If it's green, it's between the min and max. If it's low, she's below the min. So what you can do then in the next run is start that EMG monitor and allow the patient to kind of practice to see what the min and max, and you basically become a bit of a cheerleader throughout the test so that they can keep their contraction in the green for as long as possible, so that the next run in the test, you're going to watch this EMG monitor and they're going to match it up so that it stays green. So anytime it's in the min, it's going to be blue and you're going to reject. Anytime it's in the green, it's going to accept, meaning it's in the green, it's between the min and the max. Anytime it's red, means it's too high, the contraction is too much, and there it's going to reject. So here you can see she got a great replication of the tracing. And then this particular run is then going to be finished once she's gotten to her 50 sweeps is probably what she has set. So here she's got two great VEMPs. So recording this CVEMP, we know that it's an SCM muscle is activated through the contraction. It's a high-level acoustic stim presented at 5 tones per second. You're going to remember the saccular afferents have a threshold at 90-95 with an increase in firing rate. So the higher we go, we'll probably get a larger response. And they're elicited by clicks or low to mid-frequency tone bursts, so 500, 750, or 1,000. They respond best to 500, and that was proven in literature. You can see the references are there. And keep in mind that age does play a role in the best frequency. So we always hear about 500 hertz as kind of a common practice. But if you do have an older patient and you don't get a response, try going to 750 or 1,000. It's not uncommon. So if you have a 70 or 75, 80-year-old patient and you don't get it, don't think that it's not there. You really should try 750 or 1,000 to confirm it's not going to be unusual. And there's a great reference there. It's been proven several times, but this 2013 article is one of the more recent articles showing that information. And then remember that the surface EMG is averaged. And I'll go back to this being averaged here. I'm a bit of a stickler for it, and there is articles to support this. And here's why. If you just look at this VEMP that's here, and if you look at it, you say, this is abnormal, right? The left side is weaker than the right side. I can see that the amplitudes are different. And if I don't correct for the EMG, this person has a 51% weakness, or if you will, the asymmetry ratio. But if I go back and I look at this EMG, or take it into account the EMG, it's not abnormal. It's 14%. So you're going to come across patients like this. And this is why it's important to monitor this EMG activity, because you can't analyze data accurately if you're not taking into account the EMG levels. If we, after you run your CVEMP on both sides, you're going to mark a left and a right with a P1, N1. We talked the last time about P13 and N23. So you'll mark one for the left and one for the right. And you may choose to add the two runs together and use that added waveform to mark to add your markers to. Once you've done that, you're going to select the asymmetry ratio icon, and then it's only going to, obviously, you're going to have those two waveforms active once you've marked and highlighted them. Then you're going to choose the asymmetry ratio or the normalized asymmetry ratio, and then you're going to get your measurement here. You'll see that it's a normalized 23.5 on this particular one that I selected for the presentation. If you have an SSCD concern, you're going to drop the decibel level to 70 and run it again. Some are in 65 or 70, and look for that SSCD. I know that there are some clinics that instead of running, if this is the concern of the patient history shows this, they'll run the 70 or 65 run first, and then run the others. So that's obviously an option for you as well. So there you go for that. And here's a great picture of a nice even CVEMP replicated nicely right in your left and marked. And then we're going to do recording your OVEMP. Two ways to record it, or a suggestion, is have them sit, look straight ahead, and then have a marked point closer to the ceiling, and just have them look up. Obviously, we want a good 25 to 30 degrees and record it. Supine, they could be laying down and then look back, if you will, to a designated spot. And here's a nice two OVEMPs here, right and a left. And those are the inferior obliques activated through the contraction. High level stim, 5 per second. It's a predominantly utricle response, and we don't need to average the EMG because we are going to assume that they are not looking with one eye and not the other. They're going to, for the most part, move equally. Questions come up all the time of what is this mini shaker thing? This is the mini shaker. We use this because bone conduction transducers don't have enough output to generate the bone conducted VEMP response. It's used in place, sometimes a triggered tendon hammer or this mini shaker. So we have this as an example of how that's used. Some contraindications for the VEMP testing, just so you can see. You've got to remember, if you have a conductive hearing loss, can abolish that response, so you want to adequately test the middle ear with tympanometry, acoustic reflex testing. We want to make sure we have no cervical spine issues when it comes to contracting that SCM. Keep in mind those patients with tinnitus or sound sensitivity, want to take care in that. Obesity, we talked about locating that SCM. And then OVEMP, of course, if we have some absence or damage to the eye, we can't make those asymmetry comparisons. Here's some guidelines that you might want to look up online to use in your clinic. The international guidelines are great. It's a really nice paper. If you want to take down that, just Google international guidelines for VEMP. They come up, that paper, it's actually a free paper. It's a nice PDF if you Google that. And then the normative data of who you want to use. Google VEMP normative data, lots of it comes up. There's lots and lots of it out there. And we're getting short on time, I'm sorry. Asymmetry ratio, most proposed, 35 to 40% for CVEMP seems to be clinically significant. Latency delays, it's indicative of a central pathology. High asymmetry ratios or low thresholds is indicative of a peripheral pathology. Keep in mind, CVEMP amplitudes decrease with age, and they're affected by the stimulus frequency and level. And for kids, keep in mind shorter latencies, larger amplitudes, right? Their necks are little. That's kind of the key for that. So keep that in mind with kids when you're testing them. I think one of the really things to keep in mind about vestibular testing today, we got to think that VNG and rotational tests assess the horizontal semicircular canals and the VOR. What does the normal VNG mean? Only that the horizontal SCC and the VOR is normal, right? VEMP assesses the saccule, utricle, inferior and superior vestibular nerve. If you add V-hit, then you assess each part of the vestibular system individually. So we got that great piece that Ian Kurthoys did in 2012. If you look at that piece of how we can assess and what to expect in the vestibular system, and I think each of those pieces gives us a nice piece of diagnostic information and what to expect in each piece. is so informative. We have really a lot of great tools today of how to assess the vestibular system. Really useful interpretation of the peripheral vestibular system. Really useful piece. I think some other things I want you to take away from today is that VEMP is really easy test to perform, CVEMP and OVEMP. First, practice on yourself. It's really easy to perform. It's not like AVR can be difficult to perform on yourself. It's a really simple test to practice on yourself. But keep in mind that VEMP provides tests or provides information that other tests can't, and it provides ear-specific information. VNG has its limitations where VEMP and adding VHIT can provide more information that VNG cannot. And one thing to remember, VEMP is a new test, and the data, clinical data, is emerging in droves. It's leaps and bounds, daily, monthly. The number of literature that comes out is incredible. It's changing, and keep Googling every month or 2 weeks, and you'll find more and more articles that are providing us more and more information. So keep looking for it. It's out there, and it's really amazing. So with that, please type in your questions. If you want to hang around, I'll try to answer them, or I can email them out. And with that, thanks for coming and taking time out of your day to take part in another Odometrics webinar. Thank you.